A bit of housekeeping. We're in the process of putting together our speaker roster for 21-22. And so please send us your suggestions, and you should be receiving an email from this in this week. And now I have the honor of introducing our grand round speaker, Dr. Christine Albert. Dr. Albert is the chair of the Department of Cardiology and the Lee and Harold Kaplowitz Chair in Research Cardiology at the Cedars-Sinai Medical Center. She's also an epidemiologist at the Brigham and a visiting professor at the Harvard Medical School. Dr. Albert has a storied career in the study of epidemiology of rhythm disorders, particularly atrial fibrillation and sudden cardiac death. Some of her seminal work includes defining the role of omega-3 fatty acids in reducing the risk of AFib and sudden cardiac death, spanning epidemiological associations to an NIH-funded randomized clinical trial. Dr. Albert has explored the role of modifiable risk factors in arrhythmias, describing the association of alcohol with AFib and sudden cardiac death. She has spearheaded the study of sudden cardiac death in women. And currently, Dr. Albert is the PI of 2 R01s from the NHLBI, focusing on discovering biologic and imaging markers of sudden cardiac death and a randomized clinical trial of omega-3 fatty acid supplementation for preventing atrial fibrillation. Without further ado, I turn the mic over to Dr. Albert.
Well, thank you for that kind introduction, and it's a pleasure to be with you all this morning, even if it is only virtually. So what I'm going to talk today about is, as we heard, predicting and preventing sudden cardiac death in patients who do not have systolic dysfunction is going to be the focus. These are my disclosures. So as we all know, sudden cardiac death is a major issue, remains a major issue. It is the majority of coronary heart disease deaths occur outside of the hospital or in the emergency room still. It still accounts for about 50% of all cardiac deaths and about 15 to 20% of total mortality. It's estimated that anywhere from 180 to some estimates as much as 360,000 sudden deaths occur in the United States per year. And when you look at that as an incidence rate, it's about 60 to 90 per 100,000. So even though there's a lot of sudden deaths, the absolute incidence per 100,000 is small because it can happen pretty much to anyone. At the bottom of the slide, you can see that there are geographic differences with higher rates in North America and lower rates in Asia, and this is not completely understood. Over time, we've made some progress on sudden cardiac death, but not as much progress as we've made on myocardial infarction. And you can see the rates of decline of myocardial infarction in Olmsted County here over time, and the rates of decline in sudden cardiac death, which has not been as steep. So again, why that is and why we haven't made as much progress isn't entirely clear. There are also racial and sex differences in sudden cardiac death that are not entirely clear either. These are data. Raj Deo at Penn led this effort in regards looking at racial differences and sex differences and finding that Black Americans were more likely to have sudden cardiac death, and men were more likely to have sudden cardiac death than women. And you can see here Black men having incidences of almost 2.4% at 10 years of sudden cardiac death. And this is after controlling for all risk factors, social demographic factors. And again, it's impossible to completely control for all these factors, but this difference did persist in these data. Now, in order to prevent sudden cardiac death, we have to really kind of understand what underlies it. And it's a lot easier if you're trying to prevent something if it's very homogeneous. And sudden cardiac death has always been thought to be primarily coronary heart disease. And for the most part, it is. I'll show some data recently that suggests that there might be other things going on. But in general, in Western countries, it's estimated that about 75% of sudden cardiac death in men is due to coronary disease in white men. But if you look at women or Blacks, Black individuals, basically the rates of sudden death, of coronary disease on autopsy or after workup for cardiac arrest are much lower, maybe about 50% at that age. And there are other things that primarily predominate. In addition, besides coronary heart disease, obviously there are cardiomyopathies, and this may the prevalence of this may vary depending upon what part of the world you're in and the prevalence of what type of cardiomyopathy. Valvular heart disease still makes up a proportion, and there is a proportion that is due to inherited arrhythmia syndromes. And again, this varies in populations. In Western countries, it's thought to be a fairly low percentage. And then there are all these other triggers and other modifiers that go into why someone has sudden cardiac death with coronary disease and someone else doesn't. And we're going to talk some more about that a little bit later. In addition, it's also important to know that the causes of sudden cardiac death vary by age. At younger ages, we're talking about inherited arrhythmias, inherited cardiomyopathies. As you get older, then coronary heart disease and other types of cardiac disease tend to predominate. Now, there have been recent data that suggest that coronary disease is even less of a piece of the pie. These are data from Xian Seng's work in San Francisco, where he did an amazing job of getting 525 autopsies, but from the coroner. And in that group of patients found that, it was about half had cardiac disease, and that there were all these other causes, in fact, that were non-cardiac, such as occult overdose in this population. Now, again, this is a unique study, and that's an autopsy-based study. And there are some biases that go into who gets an autopsy for sure. In addition, it may depend upon where you are in the United States, what types of underlying causes could underlie sudden death. But again, in these data, similar sex and racial differences were found in that men were more likely to have cardiac disease than women. And also there were higher rates of sudden death in Blacks versus Asians and Hispanics and whites, and the same thing for men versus women. So what is the mechanism of sudden death? Well, from autopsy studies, from epidemiologic studies, about 88 to 92% of deaths that occur within 1 hour of the onset of symptom also have an abrupt collapse, which is operationally considered an arrhythmic death. Now, we know as physicians, other things can cause an abrupt collapse, like a massive PE or a dissection, but these don't end up being large pieces of what we see when we have autopsies of sudden cardiac death. So for the most part, it's thought to be ventricular fibrillation underlying these sudden deaths. Now, the proportion of people who are found in ventricular fibrillation has declined over time. And that's, again, not clear. Does it mean that the proportion of sudden cardiac death that's due to VF is declining? Or is it that there are other causes that are starting to increase, or people are being found later? It doesn't seem to be the latter. The age of people has increased, but over time, these are data from Seattle showing that, in the 70s, 60% of patients were found to be in ventricular fibrillation. And now, more recent data, it's only about 25% in the same city with the same sort of advanced EMS system. And if you look across the United States and Canada and the ROC Consortium, 22.9% of patients have VT or VF as a shockable rhythm at presentation. The reason this is important, of course, is that VT-VF is much more treatable. Survival to hospital discharge has improved over time for VT-VF. There have been some improvements in asystole and PEA, but not as dramatic. So obviously, having less patients who present in VT-VF means that perhaps less that we can do at the time of their cardiac arrest. And survival to discharge amongst all patients who suffer a sudden cardiac arrest is 7.9% to 10%. So again, not great, even though we do have so many advances with cooling and with CPR and AEDs, we still don't have great success rates for survival from out of hospital cardiac arrest. Now, one of the things that, so the question is VF not the issue anymore? But in this study, where they've actually looked to see where the patient was found, whether an AED was applied, if you were found in public and an AED was applied, you still were 80% likely to have ventricular fibrillation. So it may be a function of either where you are or else how quickly you can get to the person to actually document the first rhythm. And again, seeing the rates at home much lower for finding ventricular fibrillation. But the problem is that the majority of arrests occur at home and don't occur in public places. So again, that is a limitation for AED therapy being effective. So there have been other approaches to trying to improve our ability to resuscitate, and a lot of these have to do with apps that can get people to the place where a cardiac arrest occurs. Ideas about getting AEDs to homes through things like drones or other kinds of initiatives. There have been studies looking at the AED post-MI and were not successful. So again, whether it's because the people don't have it ready or ready to be used, or again, just not being witnessed, which really needs to happen. And then there are a lot of technologies being developed that would be constant monitoring technologies. And then if you connected those to Bluetooth, perhaps you wouldn't need to be necessarily witnessed for the EMS system to know that you have a cardiac arrest. But again, they would have to get into your home, and it is difficult, but people are trying to work on this kind of an approach. So part of this is the argument for really thinking about prevention, because treatment is so difficult, given that the majority of arrests are unwitnessed, occur at home, and therefore preclude resuscitation attempts. So what are our current approaches to preventing sudden cardiac death? Well, for the most part, as electrophysiologists, we are focused on implantable cardioverter defibrillators for high-risk patients. And as you know, there are two types. One is transvenous and one is subcutaneous. And these are generally put in high-risk patients, so patients with low ejection fractions and heart failure as primary prevention, or with inherited cardiomyopathies that have high-risk features. There are also temporary high-risk situations of wearable defibrillators. And again, these are things that can be utilized in the short term when we're not completely sure where a patient is going to fall out with regards to their risk. However, these are, as you know, for anyone who's prescribed this or had a patient wear this, the uptake is not great because they are bulky, they are difficult. This is a good way to get patients to want to have a defibrillator because they want to get rid of the temporary defibrillator. So again, the uptake hasn't been huge because of limitations in the technology. But we do know that there is a risk of sudden death post-MI that occurs acutely. And so this is where that potentially might come into play. In addition, we know from these data and from data that is old that ejection fraction is a main stratifier of risk. However, if you look at those with an ejection fraction of greater than 40%, you still see a significant amount of risk in patients who have cardiac disease over 36 months. So we can't completely ignore those patients. However, we do have a number of trials that have been done, all listed here, some of which try to risk stratify those patients to try to put them into higher risk categories. But in general, the ones that have been successful have primarily been the ones that used a broad heart failure population and did not target. And so today, this is our practice, to place ICDs in patients who have coronary disease and left ventricular ejection fractions of less than 30%, or SCDF criteria less than 35% with class 2 or 3 heart failure. We still do have the must criteria for those that are less than 40. We can do an EP study in those patients, and if they have non-sustained VT, and then put in an ICD. And again, this doesn't address some of the acute risk of sudden death that occurs post-MI, because studies have been done in that post-MI period and found that you did not prevent sudden death or improve mortality in those patients. You may prevent sudden death, but there were higher rates of non-sudden cardiac death in those that were randomized to the defibrillator. And so the idea was to try this vest as a temporizing approach and to see if that would work during this acute phase while we're waiting for a patient to identify whether someone needs to go on mute. And while we're waiting for a patient to identify one way or the other as to whether they're going to have a low ejection fraction. And so the VEST trial was done in this patient population, low EF, acute post-MI, and the overall results, which was the overall endpoint, was sudden death or death from ventricular tachycardia, and it was not significantly reduced. But as you can see, the hazard ratio was quite low. There did seem to be benefit. The problem is that powering a trial like this is so difficult because if you look at the absolute incidence, it was so low. We knew that that was going to be the case. So it is tough to power a trial. It would have to be really much larger to have the kind of power to detect a hazard ratio even of that magnitude. But one of the things that's interesting is it did show a benefit on death from any cause. Now, again, this wasn't the primary endpoint, but it is suggestive that perhaps there is some benefit with this technology early post-MI. Now, one of the limitations to this whole strategy is that when you go through this and you think about putting ICDs in these patients with low ejection fractions, only about 10%, and these are older registries now, it may even be much less in the current era, end up with an ejection fraction that is anywhere in the range where you would start to consider an ICD. And of those patients, only about 1.2% in this registry ended up getting an ICD, either because their ejection fraction might have improved or because they were lost to follow-up, or they did not want the technology. So it's not penetrating a lot of patients that are post-MI. In addition, in the heart failure population, the low EF population, we've developed multiple therapies that are actually very beneficial potentially for sudden death. And over time, the rate of sudden cardiac death in this population has seemed to decline. So not only are we impacting less patients post-MI, in the patients that we're impacting, their rate of sudden cardiac death seems to be going down as well. In addition, if you look at it from a population level, and this is work from Dr. Chuk's group that he is with me at Cedars-Sinai, Oregon SUDS, in this seminal paper showing that, the majority of patients that have sudden cardiac death do not have a low ejection fraction. And you can see, especially in women, very few, about 20% in his study had a low ejection fraction. And this is actually probably biased to finding structural disease because this is a sort of real world population where you'd only get an echo, generally if you suspected cardiac disease. So there may be even less low EFs in a broad population of sudden cardiac death. And when they looked at this, again, we look in their data, they found that only 4.4% of sudden cardiac arrests that occurred would have fulfilled the criteria for primary prevention ICD before their death. So as far as employing more ICDs in the population, the number of sudden deaths that we would actually prevent is actually potentially quite small. So what about all these other sudden deaths? If you look at them, the piece of the pie that maybe we're treating with ICDs is maybe about 20%. Overall, again, that study suggested an additional 4%. But if you look at all the patients that are getting ICDs already, it may be that piece of the pie. And what is the others made up? Well, the other is a large portion of these patients that are either post-MI, have coronary disease with some sort of risk factor, or heart failure with preserved ejection fraction. But the other concerning thing is that about 50% of patients will have no known heart disease. So again, how do we prevent sudden cardiac death in those patients? So risk stratification tools have been developed besides the EF. It's the one that we continuously go back to because it works to some degree. It actually works pretty well. But there are numbers of things that we've tried to use, and EP testing is one, which also works. But practically it's invasive. And it's so invasive that you want to really be sure that, if you get a negative results, that you have a really low risk of sudden cardiac death. And unfortunately, in the MUST trial, it wasn't low enough to really use it sort of in a widespread way. There's also autonomic testing, MIBG testing, MRI, which has been, thought of as very promising, because a lot of studies have showed relationships between scar feature and scar and sudden cardiac death. In silico computer modeling, we are working with Natalia Trianova, who's doing a lot of this using AI, trying to predict which ventricles might actually be more pro-rhythmic. And then there are some simple things like using the ECG and genetics and biomarkers. And we've chosen to focus on the latter primarily because this is really such a broad population. When you talk about moving to the population who have ejection fractions of greater than 35%, or even the general population, you're going to have to screen numbers of people like you do for cholesterol, for coronary disease. So you need something that can be applied pretty easily and broadly. So when we look at biomarkers, there have been a number of relationships. Primarily, most of the studies have been done in general population samples. Small studies, generally about 100 to 120 sudden deaths, because sudden death is a rare event in healthy populations. And so relationships have been found for inflammation, NT-proBNP, fatty acids, and very reproducible associations, higher levels of omega-3 fatty acids associated with lower risk of sudden death. Magnesium has been associated with lower risks. Metabolic markers, glucose, hemoglobin A1C associated with higher risk. Troponin associated with higher risk, and markers of renal dysfunction also associated with higher risk. And you look at each of these individually and you see about odds ratios of 1.3 to 1.5 for continuous variables, and you might even get up to an odds ratio of 5 for the highest quintile of an extreme cut point. But again, we're talking about a fairly low absolute risk population. One of the issues is that with these studies is that the low number of events in each prospective cohort. You need to get the biomarker before the event, so it's hard to do a case control study. So what we took for a tact here was to combine a number of studies and show that, that these biomarkers sort of replicated within the samples, and also then putting them together with power to really estimate the association. And so these 6 prospective cohorts from the Harvard School of Public Health area, Brigham Women's Hospital, came up with 631 sudden cardiac deaths with blood samples amongst 112. And again, these are pretty well-defined sudden cardiac deaths, filling a rigorous definition of death within 1 hour of the onset of symptoms. And we matched these to cases and to controls from the same population based on cardiovascular disease at the time of presentation, based upon age, obviously, gender, and these are all pretty much Caucasian populations, but also on race. And one of the things that we found was that hemoglobin A1C, the marker of diabetes, was very strongly related to sudden cardiac death within each cohort and in the overall cohort. And the relative risk remained even after controlling for diabetes. And as you can see here in the diabetics, even when you stratify, you see a risk. So it looked like a really good predictor, at least in the general population. Interestingly, though, we saw this difference in patients who had coronary disease or known coronary disease, were really the ones that did not have known coronary disease, were really the ones that we saw this elevated risk. And this theme will come back later, that it's probably going to depend on the type of population that you're screening, where these markers may or may not be useful. These are data that Brendan Everett published recently, looking at just the variety of cardiac biomarkers, and again, in the same population, replicating and then showing the combined associations. And each of these biomarkers was individually associated with sudden cardiac death, even after controlling for all the factors that you see below. Cholesterol was associated, troponin was associated, NT-proBNP, and hsCRP, and they were individually associated with sudden cardiac death. So again, something as simple as cholesterol being associated with sudden cardiac death had been debated because it hadn't really been shown. But if you put these samples together, we were able to show this. In addition, if you took certain cut points, you could get up to odds ratios, such as having an HS troponin I greater than 59 or an NT-proBNP greater than 300 of a threefold odds ratio. So again, controlling for each other. And then if you put together a score, and this is, just sort of arbitrary, taking the top quartile of each biomarker, and if people have each of those, so are in the top quartile of each biomarker, they had a 7-fold increased risk of sudden cardiac death. So it's pretty extreme, but again, what happens with each of these risk stratifiers is that you end up stratifying and coming down to a very small population. But perhaps this is exactly what we want to do in the general population, which is so broad. In addition to these cardiac biomarkers, we have also looked at the fatty acids, and again, replicated the association between EPA and DHA being protective, and also found novel associations with arachidonic acid being protective and oleic acid being adverse. And again, oleic acid is a marker of carbohydrate intake, and is also found in diabetes. So it's consistent with the hemoglobin A1C results. Now, those are the results for biomarkers. With regards to genetics, I showed you that, that pie graph, and this is where it starts to become an issue, because when you want to discover genetics, you want homogeneity, and sudden cardiac death is somewhat heterogeneous, as we've talked about. And so we haven't had a lot of success on sudden death as we have for coronary disease, atrial fibrillation, and other outcomes. Part of it is a numbers game because we don't have a lot of numbers, and part of it may be the phenotype. But there have been 2 GWASs here at the bottom that found what we were excited about, odds ratios of 1.78 for the Coxsackie and adenovirus receptor, and this BAS2B, which was a rare variant. But this, again, was not able to be replicated in our most recent GWAS, about 4,000 cases. So 4,000 cases compared to what you have in coronary disease is so much smaller. And so this may be the issue is a power, but at this point, there hasn't been a novel gene that's replicated that's specific for sudden cardiac death. However, there are other tacks that you could take, in that, finding the genes that predict the underlying substrate might be helpful in predicting sudden cardiac death in the general population. And this is looking at coronary disease SNPs. And so there's been a move towards using polygenic risk scores. And these are, multiple genes that have been associated with coronary disease. And in this Finnish population, they found that if you took those genes, you could risk stratify a patient population that was going for stress test. And we and others have found that these genes predict sudden death in a general population. So again, these potentially could be useful for risk stratification. In the most recent GWAS, which was led by Dan Arking and Forum Asher outside of Hopkins, that we participated in, as you can see, again, these CAD SNPs, coronary disease genes, were clearly associated with sudden cardiac death, again, demonstrating that coronary disease underlies a lot of sudden cardiac death. But interestingly, we also found that QT interval genes were associated, and body mass index genes. And again, this is sort of a Mendelian randomization suggesting that these features are causal. And there's been some debate about body mass index, that it may actually be protective in certain circumstances, and probably a lot of that is confounding, and it is adverse for sudden cardiac death. Now, we recently published with Amit Kara on rare variation, where we haven't succeeded with common variation, we wanted to look at rare variation. And again, using that same case control set of about 600 cases and 600 matched controls, and this is what they were all matched on, we sequenced and then went through and analyzed, not I say we, but I didn't do this, Karen and his group did this, at 49 genes, variants in 49 genes, and not just coronary disease genes, not just inherited arrhythmia syndromes, but also cardiomyopathy, aortopathy, and aortic dissection. And they went through and they curated each of these with a clinical geneticist according to ACMG criteria. And the geneticist was blinded to case control status. And so these are just, again, some features of these cases, again, bringing out the fact that these are mainly Caucasian white individuals. But you can see that they weren't young necessarily at the time of their sudden cardiac death. This was a sort of general population, and only about 39% had coronary disease known at the time of their death. And this shows you the amount of work that went into this, the number of variants that had to be filtered and then analyzed, and then coming up with, out of this number, 14 variants, 4 that were considered to be pathogenic and 10 likely pathogenic, and the rest were considered to be benign or of unknown significance. And when we looked at the association unblinded, we found that all of those variants that were either pathogenic or likely pathogenic were found in the cases, and none were found in the controls. So again, suggesting that this may be something that once we have exome sequencing in the population, or perhaps in response to, instead of doing autopsy, which we don't have, maybe a genetic autopsy, that potentially this could be useful. And as you see, they were on all types of genes, cardiomyopathy genes, coronary disease, not necessarily in the arrhythmic syndromes, but a few in those, and even in aortopathy. And then with colleagues from the MESA group, we then looked at how prevalent these variants were in a general population. And about 1% of the general population had these variants. And you can see the distribution of the different variants and where they were. And then we also looked at phenotypes, and so found that, you know, the variants associated with long QT were tended to be associated with longer QT intervals, variants associated with hypertrophy tended to be associated with some hypertrophy, and obviously the LDL receptor variants were associated with high cholesterol. So they did identify phenotypes that could potentially be intervened upon if we knew about this ahead of time. And overall in the population, they found that the risk of cardiac mortality, so they didn't have sudden death or the numbers, was higher if you had one of these pathogenic or likely pathogenic variants. And this just shows the variants that were found, a lot of Titan variants, LDL receptors. And again, this was a health professional population where you think a physician might know that they have an LDL receptor mutation, but at this time did not, primarily because they are historical as well. And then some arrhythmia syndromes. Now, that's what's known about genetics and biomarkers from our group, and summarizing the best I can from other groups. With regards to ECGs, been numbers and numbers of papers looking at different ECG markers, some of which are summarized in this group here, and their association with sudden death. And I already mentioned the importance of the QT interval. And Dr. Chug in Oregon SUDS and also in ERIC validated a ECG score that had several abnormal parameters from this group, and found that over time you could find a high-risk population that had maybe a 6-fold increased risk of sudden death over 14 years in a general population just utilizing the ECG. Again, probably not at the level where you would necessarily do anything like put an ICD in, but again, a high-risk population. Now, one of the problems about all these studies in the general population with regards to risk stratification is that the risk in the general population is low. As I mentioned before, it's on average between 50 to 90 over 100,000. So getting to this level, which is the 3% per year, which is what was found in the placebo groups in the randomized trials that showed a benefit of the ICD, is just probably not going to happen. So in the general population in general, with this genetics, perhaps this could be useful, perhaps the biomarkers could be useful to identify the sort of high-risk patients that you could potentially do other things for. Broadly, healthy lifestyle is pretty much where we are at. And there are many studies suggesting an impact. This is one that we did a while back, showing that if you did not smoke, you had a healthy diet, you had a good weight, you exercised, you had a very low risk of having sudden cardiac death. 88% reduction in the risk of sudden cardiac death in the Nurses' Health Study. Again, very few women did all of these things, but if you did do all these things, you potentially reduce the risk of sudden death significantly, and the population attributable risk was estimated to be about 81%. So since we're not going to be going there, are there ways to risk stratify some of these other populations? And there's been work in HFpEF where we estimate the absolute risk is about 1.2%. And this is work done in the TopCat trial, where they found that, again, men in this group were at higher risk. And patients who had insulin-dependent diabetes were also at higher risk. And you could get up to a 2% or 2.9% per year in those patients. And again, unfortunately with spironolactone, which was hopeful to be protective, these investigators did not find a lower risk associated with treatment to spironolactone. Again, not that was significant. Now, what about post-MI patients? Again, we don't really know what the contemporary risk is in post-MI patients with ejection fractions greater than 35%. The reason I bring that up is because we are primarily putting in defibrillators in those who have ejection fractions less than 35%. So this is the population that I'm going to conclude with and tell you a little bit more about. So most of the biomarker studies have been done here. And what we've done is we've tried to come to a higher risk population. And this is a population that already has coronary disease and has a left ventricular ejection fraction of greater than 35%. But we did choose one risk factor. They either had to have mild to moderate LV dysfunction, somewhere in the range of 30 to 50%. But they could not, or an MI. They had to have at least a history of MI. So they couldn't have coronary disease and a preserved EF alone. They had to not fulfill consensus guidelines for an ICD. And what we did in Predetermine is that we collected, and these patients were enrolled over a long period of time. The reason it was so long is that they were initially part of a randomized trial that did not get off the ground because of the lack of uptake of doing MRI in patients who have coronary disease and randomizing to a defibrillator. So we had to enroll these patients outside of the randomized trial, and we did that in the last 2 years. And we collected data, lifestyle information, blood samples, and we've been following these participants centrally for cause-specific mortality with a primary endpoint of sudden and or arrhythmic death and VF arrest. And there's 5,700 patients. And our goal is hopefully to identify a series of easily measured biological and ECG markers that predict the risk of arrhythmic death as opposed to other causes of mortality. And the reason that we want to do that is I'll show you a little bit about competing risk and why that is so much more important in this population than perhaps in the general population, where you're just trying to identify a broad population that you're then going to, kind of intervene on the substrate. But here you're talking about potentially risk stratifying for an ICD. So these are the baseline characteristics. The ejection fractions are preserved here. As you can see, the mean ejection fraction is 52%. The mean age of the cohort is 64, 75% men. We did try to enroll minorities. It was difficult, but we managed to get about 11%. As you can see, this is a very well-treated population with regards to current guidelines, and also very few of them had heart failure. So that's something to mention. So our first publication just kind of documented what is the absolute risk of sudden death in this population. And we had followed them for a median of 3.9 years. And at that point, we had 125 sudden deaths. Then that ended up being a 2.1% absolute incidence. So 0.53% per year, so a lot less than the per year that had been seen previously for ICD patients, but again, 10 times greater than the general population. So you've already gotten there, 10 times greater. And the other thing that was interesting in this population versus a low EF population is that the primary cause of competing risk was actually non-cardiac causes. So unlike a heart failure population where it's often heart failure, death, and cardiac causes, maybe things that stratify risk that predict cardiac disease might work better in these populations. But again, the number of absolute incidence of other deaths, again, is much larger than that of sudden cardiac death. And that's seen pretty much in all populations at this time, even in the low EF population. So what we're trying to do now is get from 0.6% to 3%. So now a score that elevated the risk sixfold would be useful in this population. So we first looked at the standard markers. What do they do? And so when we look at LVEF in this population, you see that it predicts sudden cardiac death risk on the left-hand side. And even if you have an LVEF of 50 to 59%, you have a higher risk of sudden cardiac death than those who have an LVEF greater than 60. So even modest reductions, we often think of it as a dichotomous variable, but it's not. The problem again with LVEF is that when you look over on this side of the graph, it also predicts non-sudden death, even though it's primarily not cardiac. And this amount sort of dwarfs that amount. Not terribly so, but it does dwarf it. And so then we try to look and see, is there anything that predicted sudden death specifically and didn't predict non-sudden death? There were clinical markers, and the only one that came out with some degree of specificity is this modest reduction in EF of 40 to 49%. And this is where a lot of people have wanted to target ICD trials, and showing that this group actually had a higher risk of having sudden cardiac death than non-sudden death. And that was borderline statistically significant. What we did find is that there were markers that could identify those that were more likely to have non-sudden death. And something that's very simple, we all kind of know about, but still we don't really sometimes use in our practice, is age. And you can see as these people got older, they clearly had an exponential rise in their non-arrhythmic death rate and had very linear and modest rise in their sudden death rates. So again, the competing risks in patients who are older is going to be a significant issue. In addition, we looked at diabetes specifically, this is now in Precedent Circ EP, and basically found what the Top Cat people found in that, insulin dependent diabetes was more than insulin diabetes, insulin dependent diabetes was more than non-insulin dependent diabetes, more than no diabetes. But we were able to look at the competing risk. And so you can see here's sudden death down here, and then here is what you see for non-sudden death. And it's so much greater in the diabetics, about 4 times more likely to have a non-sudden death event. So when you put this all together, and just to exemplify what can happen with competing risks, we wanted to estimate, well, what would be the number you would need to treat to save one life in these populations with a defibrillator? And we made a few assumptions. We assumed that the ICD would reduce sudden death by 60%. And this is an assumption based upon the reductions that are seen overall in ICD trials. Some had more, made it had like 80%, but we went with a conservative estimate. And over time, if you can see, if you suspect that 60% would be reduced based upon the proportion of deaths, you would see that basically this group here, LVEF 30 to 39%, and New York Heart Association class would have the highest absolute risks and then would have the lowest number needed to treat, 34 and 32. And so that's sort of like what we've been doing. And, that makes sense in the sense that, those numbers needed to treat aren't astronomical. But the problem lies when you think about your percent reduction. So if you have a 60% reduction on sudden death, you're not impacting other causes of mortality. And so your percent reduction is actually highest if you were younger. Now your absolute risk was low, so your number needed to treat would need to be very high. But this comes into powering a randomized trial, because your randomized trial depends upon your mortality benefit and your absolute incidence. So this has to be taken into consideration. And when you look at it, New York Heart Association Class 2 actually had the lowest potential projected mortality benefit because the largest proportion of those patients' deaths were non-cardiac. And this came into play in the Danish trial. If you look at the results stratified by age, you see that there actually was a benefit of the defibrillator in the younger patients. And this has to do a lot with the proportion of deaths due to sudden death in this group, the younger patients, versus as you got older, the proportion definitely declined, such that you saw this linear relationship between an age treatment effect. So things that we need to consider in future trials. In addition to clinical factors, we have also looked at the ECG and have used a really simple risk score that could be easily done, just looking at Q waves, Q restoration, LVH, and JTC, and looking at this in this coronary disease population. And we're able to replicate in another coronary disease population, Artemis, that this score helped to risk stratify patients significantly for their risk of sudden cardiac death. And this is Neil Chatterjee's work, who's now in Seattle. And you can see that those in the high-risk group who had greater than 3 points on the score had absolute instances of sudden cardiac death around 6% at 5 years. And then if you took that moderate EF, you could get it up to almost 7%. And notably, you had very low risks in those with a very low risk score. The other thing that was very promising is that this score helped to discriminate sudden death versus non-sudden cardiac death in both cohorts, such that it was associated significantly with sudden death and not after adjusting for other risk factors with non-arrhythmic death. And here, the proportion of deaths that were sudden were 28%, which again is not as high as the young people, which was almost 50%. But again, if you combine those with different risk factors, you might be able to get that up. And then when you combine it with clinical risk factors, you are able to even come up with higher absolute risks, such that if you're in the highest risk factor of clinical risk factors, including LVEF and other risk factors, you can get to a 8-fold risk in 5 years. And so now you're talking about risks that are approaching where we would put an ICD in hypertrophic cardiomyopathy patients. In addition, you can use the ECG potentially to screen for myocardial scar features that might be associated with sudden death, and therefore maybe decide patient populations that would be benefit from further screening. And we showed that with, again, another simple score, able to identify MRI scar size, which has been associated with sudden cardiac death. And most recently in non-ischemic cardiomyopathy as well. Now, as far as biomarkers, we are just starting because our numbers are just building up, but we did look at hemoglobin A1C because this was the first thing we looked at in the general population, and again found that that hemoglobin A1C risk stratified. But as you can see here, it's very similar to the result that we found with diabetes, in that the diabetes was associated, but they were much more strongly associated with non-sudden death in this population. And again, about a 4-fold increased risk there. So this is an issue for using this to risk stratify. And within the diabetics, it no longer predicted sudden death. So very different and actually kind of consistent with what we found before, that it's not as useful as a risk stratifier once you have already developed coronary artery disease. We do have some promising data though for some of the fatty acid measures, which might help to risk stratify. These measures over here, including the N3 fatty acids, are associated with sudden death and show favorable associations, and some other novel markers, and also some markers that are associated with non-arrhythmic causes. And so as you can see, DHA here is associated with non-arrhythmic causes. So we're working through this and trying to see if we can use this to help to discriminate who will be more likely to die from sudden cardiac death versus not. We've also done some studies looking at microRNA and want to do this hopefully in the entire cohort where we looked at microRNAs that are associated with fibrosis. And this is Samia Das and Mike Sivelin's work at Mass General, and found that, you know, some of these RNAs are associated with sudden death. And if you put them together in a score, you can get up to 5-fold. So again, this would get you possibly to where you might risk stratify. But this was a case control, and we have no idea in a case control setting how they deal with non-arrhythmic death. So that's why we would like to do it in the entire cohort. So what we do have in the entire cohort is a number of biomarkers listed here. Fatty acid profile, genome-wide genotyping, we're going to present some results on that at APHRS, ECGs, and in subsamples, we have MRIs in about 600, and we are now connected to all the ICD companies because some of these patients have gotten ICDs because their EF has gone down or they had a APHRS, and we're actually following the ICD therapies as well. So in summary, there are unexplained racial, ethnic, and sex differences in sudden cardiac death. The proportion of cardiac deaths due to VF appear to be decreasing, and the majority of deaths, unfortunately, still occur at home. Coronary disease underlies a significant proportion of sudden death, but it's not all of it. So preventing coronary disease hasn't necessarily translated completely to sudden death, and it also varies significantly by race and sex. The majority of sudden deaths occur in these moderate to low risk populations where we really don't have any effective methods of risk stratification yet. And our current risk stratification method, LVEF in high risk populations, has some limitations and has been having some diminishing returns over time, potentially. So to move beyond the low EF population, we're going to need inexpensive and readily applied sudden death risk stratification methods to do it in this large population. And these markers have to be smart. They have to not only enrich absolute risk, but also the proportion of deaths that are due to sudden death in order to identify populations where these sudden death prevention strategies will have the greatest impact. Once we develop something that can be broadly applied to the general population and reduce sudden cardiac death, such as lifestyle factors, then this won't be as critical, but where we have the ICD as pretty much our only method right now preventing specifically sudden cardiac death, then we need to think about this. And younger individuals have the higher proportion of deaths due to sudden death. And so therefore they are projected to have the greatest mortality reduction, and so probably should be the focus of randomized trials going forward. And preliminary data suggests that standard ECG markers may be useful to improve sudden death prediction over clinical markers. We have some data for genetic markers as well that we'll be presenting soon. And so hopefully future directions will be to combine these markers. We now have 240 arrhythmic events in this group of sudden deaths and ICD therapies, 225. So we're getting to the point where we now can combine all of these to find hopefully an elevated subgroup at high risk. So, and then finally, hopefully someday we get some alternative approaches beyond the ICD which target the substrate. We have all our approaches for coronary disease and heart failure, which are important and we should be employing, but hopefully we get something more specific. So I thank you for your attention.
Thank you, Dr. Albert. That was phenomenal. So we have 5 minutes for questions, and I'm happy to sort of monitor the chat. Dr. Jacoby has a question. Are you exploring the value of VUS genetics as part of risk score development?
Yeah, so we in the Harvard cohort study, which was the general population, we did do exome sequencing, and so we do have VUSs there. And when we went back and looked at things that was possibly pathogenic, we didn't see that same association. It really was limited to those that fulfilled the criteria. Now, again, that's a small sample, and so it's 600 cases. And when you think about looking at exome sequencing and doing it, you would need very, very large numbers in order to find associations between VUSs and sudden cardiac death. In predetermined, we do not have exome sequencing at this time. We just have GWAS. But hopefully we can do that at some point so that we could look at rare variation there as well.
Perfect. And Dr. Money has a question. He has his hands up.
I think it was an excellent talk, and I noticed you mentioned the value of exercise and daily exercise, and I wonder if actually cardiopulmonary testing could actually determine it's like MbO2 people at high risk. And now that brings me actually to another topic, and that is that exercise, what it does epigenetic changes.
Yeah.
And you had very few number of rare variants in such a large population. I wonder, actually looking at the DNA methylation, histone modification actually may add values, because as you see, I mean, the lifestyle changes does actually impact the sudden cardiac death.
Oh, that's a great point. And I think one of the major frustrations, as I mentioned earlier, is just our lack of numbers to do those kinds of important analyses. There's all kinds of interactions. I am positive, and you're right that lifestyle has a major impact and may be working through what the mechanisms that you're talking about. It just is difficult because we just don't have the numbers. And I think, just the phenotype is so difficult. I mean, I didn't go into that specifically, but, to what we do, at least in predetermined, is we call every relative and we, get every record that we can. And still, sometimes we know that we're not picking up all the sudden deaths that occur in that population. It's a very difficult phenotype, but I agree with you. It would be great if we have enough numbers to do that kind of work.
Thank you.
Any other questions? Okay, I got the last answer to the question. Excellent work and talk, Christine. As your work is addressing dietary fat and risk, can you speak to what we know vis-a-vis nutritional strategies to reduce population SCD, that is Mediterranean diet?
Sure. So we have looked at a number of factors, and that study that I summarized that showed the 80% reduction if you had a good diet. That diet specifically that was looked at was the Mediterranean diet, and that was associated in that study with about a 50% reduced risk. But we've also looked at other specific parts of the diet, and particularly omega-3 fatty acids, fish consumption, alpha-linolenic acid, and all those omega-3 fatty acids, long chains, have been associated with reductions of sudden death in the general population. Now, with respect to supplementation of omega-3 fatty acids, as you know, the data is somewhat mixed, with very promising results from GISSI, then not necessarily followed up by some smaller trials that occurred later. And as far as the general population, we have followed sudden death and vital, and we will be working on, we are working on a description of those results where we had omega-3 fatty acids, but we only had 70 sudden deaths in that general population. So our power was really low. And again, how do you prove that? I think that, the smart thing to do is to eat a healthy diet that we know is very beneficial for a number of things. And those fats that are potentially beneficial are those that are found in fish and olive oil, and just eating a healthy diet.
Perfect. I think that's about it. Thanks so much for taking the time to talk to us. It's such an engaging conversation. And thank you.
No, thank you for having me.